Good morning. My name is Dr. Johnston, and I want to welcome you to our Grand Rounds presentations this morning. I want to particularly welcome those that are on the internet. You're going to be in for a very rewarding period of time here that you spend with us this morning. These students up here are part of our first year medical class. The composition of this group of students is coming together to present a case that has been taken from Medscape. These are first year medical students, and these students have not participated as of yet in clinical clerkships or rotations. And what they've done in this first semester of medical school is to build on the basic fundamentals, anatomical correlation, and then reviewing articles with a case that has both clinical, research, ethical concepts integrated into the case. This course is part of the medical informatics course that Mrs. Lori Fitterling and her supportive staff have put together. This is an exercise that helps to teach these students how to work in a collaborative manner, how to break up into a team, some of whom are assigned to research, others to treatment, and others to ethical consideration. There are links on the web for questions, and then certainly we're open for questions. If you have a question, you come on down and present it to the panel. So that's enough said from my part. Doc is going to present a case here of a young girl with clumsiness, dystonia, and speech difficulty. I hope you enjoy it. If you have questions, please feel free to bring them down.
Good morning, everyone, and welcome to Grand Rounds. My name is student Dr. Brett Heber, and I will be the first of two presenters today representing Group 3 as we lead you through the case of the young girl with clumsiness, dystonia, and speech difficulty. These are the members, the student doctors, of Grand Rounds Group 3 who have worked very hard over the past few weeks to bring you today's case. Let's begin with some background. A 17-year-old girl is brought to the outpatient clinic by her parents, who display concern over progressive clumsiness, which has persisted over the last 6 months. The patient also presents with dystonic movement in all of her limbs. This is characterized by contractions which are causing the limbs to be abnormally twisted. The patient also has deteriorating speech and declining ability to walk, which has also persisted over the last 6 months. Her parents also display concern over recent excessive salivation. There is no history of fever, headache, focal weakness, visual changes, bladder dysfunctions, convulsions, or trauma. It should be noted, however, that 1 year ago, our patient developed jaundice, which persisted for 4 months before resolving spontaneously. Now, medical follow-up at that time was unable to discern a clear etiology for that disease. However, there was no sign of liver failure. The patient's birth history is relatively unremarkable. She is the third child of a non-consanguineous marriage. Now, that is a marriage of two individuals who are not first cousins. Otherwise, she met all developmental milestones and is otherwise healthy with no chronic medical conditions. She has no recent travel and denies the use of medications, alcohol, tobacco, or recreational drugs. The patient has no known allergies to medications, and her family history is unremarkable. Upon physical examination, our patient appears to be a mildly jaundiced young woman in no distress, and she is generally well-appearing. Cardiovascular exam shows regular rate and rhythm with no murmurs, gallops, or distress. Pulmonary exam findings reveal clear auscultation bilaterally with no wheezes, crackles, or adventitious breath sounds. GI findings reveal that the liver is firm and non-tender, and there is no splenomegaly. Our neurological findings are quite extensive and include slow mentation or slow mental activity, slurred speech, ataxic gait, diffuse muscle rigidity, a fine resting tremor, and reflexes which are brisk bilaterally. HEENT findings reveal icteric sclera, or yellowing of the sclera of the eye. Pupillary reactions to light are normal. The patient also displays normal visual acuity, and the optic fundi appear to be unaltered. It should be noted that our patient displays dark brown-colored rings around the periphery of both irises. The patient's mucous membranes also appear to be moist. And so in these images, first, the image on the left, we can see these dark brown-colored rings surrounding the periphery of our patient's irises. And while this image is not of our patient, this is a great example of the icteric sclera, or yellowing of the sclera, that we have also found in our patient at this time. Dermatological findings reveal that there are no spider nevi nor palmar erythema. Now, palmar erythema is redness of the palms. Initial lab results reveal that we have CBC and ESR findings which are within normal limits. Liver function tests, however, reveal elevated levels of total bilirubin, elevated alanine aminotransferase, elevated alkaline phosphatase, and our ProTime is also found to be elevated in this patient. Hepatitis B and C markers are negative, and initial MRI findings reveal hypodense regions in the basal ganglia of our patient. So if we look at this MRI image, we can see the basal ganglia, and normally in an MRI of a healthy patient, this would be completely white. However, we see these 4 darker regions, or hypodense or less dense regions, which are of concern at this time. So having considered what the patient has told us, our physical exam findings, and our initial lab findings, we move now to our differential diagnoses. These include cortical basal ganglionic degeneration, progressive supranuclear palsy, multiple sclerosis, and Wilson's disease. Cortical basal ganglionic degeneration, or CBD, is a neurodegenerative disease affecting cognition and motor regions of the brain. The disease is characterized by the aggregation of tau protein and is related to other tauopathies such as dementia and Alzheimer's disease. The average age of onset for CBD is 60 years, and symptoms include asymmetric movements, impaired voluntary motion, twitching, alien limb phenomena, dystonia, and impaired speech. It should be noted that our patient did in fact display dystonia and impaired speech. However, our patient's age of 17 and the average age of onset for CBD of 60 years makes it very unlikely that a young woman of this age might have developed CBD. In addition, our patient also does not display several of the other very characteristic symptoms. Moving then to our next differential diagnosis of progressive supranuclear palsy, or PSP. PSP is an atypical Parkinsonism disorder in that the symptoms of this disease are similar to those of Parkinson's, but the disease itself is caused by the degeneration of a different set of nervous system cells than those that lead to Parkinson's. Generally, this disease is characterized by muscle weakness associated with damage to the brain nuclei. The average age of onset for PSP is 62 years, and symptoms include abnormal gait, dysarthria, which is difficulty using the muscles involved in speech, dysphagia, which is difficulty swallowing, rigidity of the neck and trunk, and also pseudobulbar palsy, which is difficulty using the muscles of the face. And again, it should be noted that our patient does in fact display abnormal gait. She's having difficulty walking, and she also has signs of dysarthria. She's having difficulty speaking. However, once again, our patient's age of 17, when considering the average age of onset of PSP of 62 years, makes it very unlikely that this patient might have developed PSP. Moving then to our third differential of multiple sclerosis, or MS. Multiple sclerosis is a demyelinating disease of the central nervous system. The average age of onset is in the young adult years and is found predominantly in females. Symptoms include bowel and bladder dysfunction, weakness, visual disturbance, gait disturbance and balance problems, as well as sharp tingling sensations in the muscles. Now, our patient's age, gender, and her presence of gait disturbance, walking troubles, make it very likely that MS does have potential as our final diagnoses. However, it should also be noted that our patient has no bowel or bladder dysfunction, and upon physical exam, her visual acuity was found to be normal. In addition, our patient lacks the typical MRI findings for MS patients of cerebral plaques, or discrete demyelinated regions with the preservation of axons. So if we were to look at this MRI image, which is an image of a patient with MS, we would see these light-colored regions. These are the cerebral plaques, or demyelinated regions. And our patient lacks those findings. Also, we should note that MS is typically found in the periventricular region, the corpus callosum, centrum semiovale, and the basal ganglion, which our patient does have findings in the basal ganglia. However, she lacks any of these findings in any of these other regions. And for these reasons, we can once again say that it is less likely our patient might have developed MS. Which brings us to our last differential of Wilson's disease. Now, on the screen, we will see the diagnosing criteria for Wilson's disease. These include dark pigmented rings around the iris, hepatic dysfunction, hypodense regions in the basal ganglia, elevated copper serum levels, and decreased ceruloplasmin levels. You'll find that the first three of these are bolded because we have already established that our patient displays these symptoms or these characteristics. She does display dark pigmented rings around her irises, as found in physical examination. Her liver function tests displayed that she does, in fact, have hepatic dysfunction, and her MRI findings revealed the hypodense regions of her basal ganglia. And so in order to test for our final two diagnosing criteria, further lab tests, were conducted. And those did, in fact, reveal that our patient had elevated serum copper concentrations, decreased ceruloplasmin levels, and she also had increased 24-hour urine copper findings. For these reasons, we can conduct that our final diagnosis is Wilson's disease. And now, to tell you more about Wilson's disease and further consider our case, I am pleased to present student Dr. Michael Getz.
Thank you, student Dr. Heber, for the initial presentation of our case. It is now my privilege to discuss the biochemical mechanism of Wilson's disease, as well as treatment options, emerging research, and to discuss the basic function of copper in the body. Copper is an essential trace element that is involved in many redox reactions as it fluctuates between a +1 and a +2 charge. Some enzymes that use copper as a cofactor include cytochrome C oxidase, found in the electron transport chain, superoxide dismutase, which will bind free radicals of molecular oxygen, and peroxidase, which will oxidize ferrous iron. Today I would like to discuss two ATPase copper transporters. The first one is ATP7A, and the second one ATP7B. In this image, we can see ATP7A is functional in the enterocytes in the small intestine. These function to absorb copper from dietary intake. These will then deposit the copper in the blood, and it will find its way to the liver, where it finds the second enzyme, ATP7B, which will transfer copper onto another protein called ceruloplasmin. This ceruloplasmin is then either taken to the bile to be excreted from the body, or it is taken throughout the blood to perform its normal physiological function. This ceruloplasmin is necessary to transport it throughout the body, as free copper is toxic to the body. Wilson's disease is an autosomal recessive inherited disorder with a mutation on the Q arm of chromosome 13 affecting ATP7B. This is ATP7B is a membrane-bound P-type copper-transporting ATPase that is found primarily in the liver, though it is found in other locations. This mutation occurs at location 1069, where a histidine is changed to glutamic acid, disrupting the location where ATP will bind. So going through this image and this mechanism of disease, ATP7A is still functional. The dietary copper is still being absorbed. However, the problem occurs down in this image in the liver in ATP7B. ATP7B will not transport copper onto ceruloplasmin. Three things will happen as a result. Copper will begin to build up in these hepatocytes. The ceruloplasmin will exit the cell as apoceruloplasmin and is secreted and quickly degraded. It's interesting to note here, this is the reason why our patient's ceruloplasmin levels were low, as this copper was not coming together to form this ceruloplasmin. And eventually, once the copper buildup is so great, the copper will begin to be secreted from these hepatocytes, and it will begin to lodge in the cornea, kidneys, and the brain. The result of this excess copper I'd like to discuss are threefold today. First, there will be liver disease, as this is the main location where copper has begun to build up. It will oxidize lipids and proteins and promote free radicals. Eventually, this will cause neurological symptoms as the copper finds its way into the brain, and it will accumulate in the cornea, causing Kaiser-Fleischer rings or KF rings, as we had noted in our patients. These KF rings are caused by a deposition of copper in the corneas. It will start at the superior aspect of the cornea, then at another location in the inferior aspect of the cornea. And eventually, once copper levels are so great, it will form a ring, as seen in this image, around the entire eye. These can be seen with the naked eye if it's severe enough, or in less severe cases, we would use an ophthalmoscope set at +40 to visualize these. 90% of patients with Wilson's disease do exhibit KF rings. However, as of today, they are not an absolute marker for Wilson's disease, as these KF rings can be indicative of conditions such as carotenemia, chronic active hepatitis, chronic jaundice, and others. Neurological symptoms will begin to form because ATP7A and ATP7B are functional in the brain tissues as well. They function in approximately the same manner as they do in the enterocytes. ATP7A, found up here in this image, will transport the copper from the brain from the blood and transport it into the brain. ATP7B is responsible for the reverse. It should take the copper from the brain and transport it back into the blood. However, as ATP7B is non-functional, there is no way to relieve the brain of excess copper, so these neurological symptoms will form as there is a copper overload. And in fact, 10 to 20% of patients with Wilson's disease initially present to the clinic complaining of a neurological symptom. We treated our patient with the standard treatment of care, which is penicillamine 500 milligrams 3 times daily, as well as advising her to restrict her dietary copper intake. Copper is found in many of the leafy greens. And after 6 months of adherence to this regimen, we saw considerable improvement in our patient. Penicillamine is a copper chelator that will bind to free copper in the body, and then that complex is then easily excreted through the urine. Alternative treatments might include a liver transplant, as in some cases the liver becomes damaged irreparably, so we would need to transplant that liver. These patients would no longer need to be taking a medication, as a transplanted liver would have a functional ATP7B. Trientine is another copper chelator that functions in the same manner as penicillamine. It does seem to have less side effects, and there are some studies, which I will discuss later, that indicate it might only need to be taken 1 time daily, though as of now, it's taken 3 times daily, just as penicillamine. After starting our patient on a copper chelator, we would consider doing OMM lymphatic treatments in order to push fluid centrally to more easily excrete the copper from the body. A typical session might include opening of the thoracic inlet, effleurage and petrissage of the upper and lower limbs, cervical stroking, and then closing the session again with opening of the thoracic inlet. As I said previously, there's research being done on trientine as a 1-time daily dose, though as of now, 3 times is the recommended dose. So I'll go ahead and take a moment to discuss this graph. On the y-axis, we have liver function as measured in ALT levels. On the x-axis, we have time as measured in clinic visits. These visits 1 through 4, the patients are taking a 3 times daily dose of medication to establish a baseline copper level. After this 4th visit, they were prescribed a 1-time daily dose of trientine. As we can see, there is some fluctuation, especially in this top green line. However, these initial baselines are approximately the same as where we ended after visit 11, potentially showing a 1-time dose is just as effective as a 3 times daily dose, and will in fact increase patient adherence to this regimen, as it's easier to take a pill once daily, easier to do that than take a pill 3 times daily. Another area of research being done is establishing a rapid and reliable diagnosis for Wilson disease using X-ray fluorescence. We would test liver samples of patients and we would get graphs such as these found on the right. This top one is a normal liver, and we see at this 8 to 8.5 mark, we see a measurement of copper here. In order to compare that with our Wilson disease patient, we need to look at this zinc and iron levels. We can see the copper is much, much lower than these two. However, in Wilson disease, at that same 8 to 8.5 mark, this measurement of copper is well above these zinc and iron levels, showing that this liver sample does have Wilson disease. This method is being tested, and it possibly will be implemented in hospitals. For patient education, we would send our patient to the Wilson Disease Association website. This website has a copper calculator, which will help the patient to track their copper levels over time. So after each visit to the clinic where a blood draw is being done, they can then go input those results to the website and see how their copper levels are trending. It will also give them information on which foods to avoid, which cooking utensils to avoid, as some of the metal ones do contain copper, as well as instructing her to avoid alcohol as much as possible, as alcohol will increase copper levels as well. Here we would also want to do genetic testing on our patient's family so that they can be informed, which leads me into our ethical considerations. Some of these family members, for whatever reason, might decline this genetic testing. It is therefore our obligation and our ethical responsibility to instruct these family members as best as possible as to the signs and symptoms of Wilson disease, so that if these do occur, they know that they need to seek out a clinician for treatment. And as there is a risk for our patient's children, we would consider sending her to a genetic counselor so that she can be informed of potential outcomes in her children. Another area of ethical consideration is penicillamine versus trientine. They have about the same neurological improvement, and there are some studies showing that trientine has fewer side effects. However, today the standard of care is penicillamine. This could be due to the fact that penicillamine is only $60 per pill, whereas trientine is about $215. And as they are each taken 3 times daily, that is a very, very big difference in medication cost. And this ethical consideration is being discussed by politicians and people around the world today. And of course, we would always respect our patient and her family's autonomy in choosing their treatment. Together, we learned that Wilson disease can present in a multitude of ways. And though it is a rather rare disease, it affects about 1 in 30,000 people, we still need to be able to identify these applicable signs and symptoms to give our patients the best care. Together, we also learn time management, team collaboration, and communication. We would like to thank all those who helped us with our presentation. These are the references where we find our information, and I would like to open the floor now for questions. Thank you.
Well, it's pretty comforting to know that the politicians are allocating the money here for this disease, and it 1 out of 30,000 cases. I know you have some questions, so why don't you go ahead and start?
Hello, I am student Dr. Julianne Gavin, and we received a question. It's what are likely causes of jaundice in a young patient? So we have a few diseases that affect the liver. One is Gilbert syndrome. This is a condition in which the liver is not properly metabolizing bilirubin. And then Crigler-Najjar syndrome, types 1 and 2. This is a rare autosomal recessive disease that results from a complete absence of UDP glucuronyl transferase enzyme. And then also, Epstein-Barr virus is an infection that can cause acute hepatitis and jaundice in older children and adolescents as well.
Hi, I'm student Dr. Ron Israel, and we received a question about why is MS more common in females? And so there's been some disagreement, but there's been several studies that have suggested that women with MS have a variation in the gene that produces high levels of interferon gamma. And interferon gamma can aggravate MS by promoting inflammation and tissue damage. Additionally, there's been other studies that have suggested that a protein called S1PR2, which controls the permeability of the blood-brain barrier, is more prevalent with patients with MS. And the study also suggested that women make more of this protein than men. So those are two potential reasons.
Hi, I'm student Dr. Ari Helfman, and one of the questions was, do you need a special light to see the Kaiser-Fleischer rings in the eye? And slit lamps are typically used for the examination, and you can also use a gonio lens, which lets you get a deeper peripheral view of the cornea, and particularly if it's kind of the initial onset when the rings may not be as apparent as someone that's had it for a while, then a slit lamp is definitely something that someone should use.
Hello, I'm student Dr. David Huber, and we got the question, are there psychiatric manifestations in Wilson's disease? And psychiatric symptoms are actually more common than hepatic involvement in Wilson's disease. And these manifestations can include depression, irritability, personality changes, and even impulsiveness.
Hi, I'm student Dr. Ashley Hacker, and my question is, what is Menkes syndrome? Menkes syndrome is a mutation of ATP7A, and like Michael said, to get copper into the body or into the cells, you need ATP7A and ATP7B. Wilson disease is a mutation of the ATP7B, but Menkes is the ATP7A. So when you take in dietary copper, you're not able to absorb it in the intestine if you have a mutation in ATP7A. So you actually have a decrease in copper in the cells. And this is characterized by kinky hair, failure to thrive. And so patients do not usually live past the age of 3.
Hi, my name's student Dr. Grant Gustafson, and I have the question, why is free copper toxic to the body? And essentially, so with the recycling of the copper between copper 2 and regular copper, that redox activity can lead to two main issues, being elevated ROS, or reactive oxygen species, and also corruption of critical proteins by adventitious binding of copper ions, or ions, sorry.
Hi, I'm student Dr. Abby Heaton. I got a great question about OMM. The question was, why do you have to wait until you start treatment of penicillamine to actually begin and performing OMM? As it was stated in our presentation, our patient has a condition in which copper is spreading and accumulating in parts of her body. Because of this, we need to allow penicillamine in her system to work first on chelating with the copper and actually starting to remove it from the tissues. Once it's there, the OMM treatment can be applied, the lymphatic treatments, to move the chelated copper from various parts of the body to the thoracic region, where it can flow into the venous system, eventually ending up in the kidneys and then being excreted from the body. If we were to attempt any lymphatic treatments before the patient begins this medication, we would not be able to move copper centrally towards the venous system, as it would still be confined in the tissues.
I'm student Dr. Caitlin Gluck, and we had the question, what is alien limb phenomena? It can present in any of your limbs, but it's most common in the hand, and usually one hand functions involuntarily, and the victim is completely unaware of its action. Symptoms can include involuntary reaching and grasping, touching the face, tearing at clothing. Really extreme cases have involved punching yourself, choking, so it can get pretty violent.
All right, very good. One of the components to young student doctor's question relevant to the psychiatric manifestations is that it's not uncommon to, if it's out of sight, it's out of mind. And frequently, some of these people with this type of disorder will present in what you think might be psychiatric etiology, when in fact it's due to an impairment with copper metabolism. So I thought that was spot on, and that was a good question. The other components, what if this patient had an elevated, as a young lady, elevated indirect bilirubin? You said your total bilirubin was high at 3.6 or so. What if the indirect portion was much higher than the direct portion. What would you be thinking about? Young person, make this a teenage, she's a teenager, make this a 6-year-old. Make it a neonatal patient. All right. The point being is you want to think about either impairment in conjugation or hemolysis. When you have breakdown of blood, the indirect portion of bilirubin will go up. So the total bilirubin is good, gives you a direction, but they didn't fractionate it. Well, they didn't provide it for you. So you want to know what's the direct and the indirect portion of bilirubin. In short, not too shabby for first-year medical students, right? Give them a round of applause, and the next group, come on up. Good job. Huh? Yeah, hemolysis.
Okay.
Yeah.
Thank you.
Do you know it? You should have said it.
Yeah.
We were looking into it.
No, I know.
Can't ruin the mojo. She's not that small anymore. An Alaskan malamute.
So, can't tell if it's working. Hello, my name is student Dr. Sarah King, and today my colleagues and I will be presenting the Medscape case, Multiple Fractures in a 14-year-old Boy. Just a brief outline of our presentation. I'll be presenting the history of present illness, pertinent physical and lab exam findings, our differential diagnoses, and our final diagnosis. And then I'll be followed by student Dr. Eli Kelly, who will provide information about important treatment and ethical considerations, followed by concluding remarks. So to introduce the case, the patient is an athletic 14-year-old boy who's been suffering from trauma-related fractures over the last 2 years. His mother specifically brought him into the office because she believes he's suffering from fractures more easily and frequently than his peers who are involved in the same level of activity. He's had 4 fractures in the last 2 years. 2 sternal fractures as indicated on this CT, 1 thumb fracture, which you can see on this x-ray, a radius fracture, which you can see here,
and he's also injured his scaphoid bone. Each of these injuries was associated with trauma during his physical activities. In addition to the current concern about fractures, the patient denies any other pertinent associated symptoms, as listed here. So no hearing changes, diarrhea, developmental delay, no increased joint flexibility or skin laxity, and no injuries or fractures prior to those sustained in the last couple of years. He does not bruise easily and has no visual deficits. He does have significant past medical history. He was diagnosed with type 1 diabetes at age 10, which he does take medication for. However, it is poorly controlled as indicated by his elevated A1C levels. He's also positive for thyroid peroxidase antibodies, which is a confirmatory antibody that indicates Hashimoto thyroiditis, which is a genetic thyroid disorder. However, he does not have the acquired hypothyroidism that is characteristic of the disease. He's also had a vitamin D deficiency in the past, specifically a level of 23 nanograms per milliliter 3 years ago. The patient is on medications. First, he's on insulin via insulin pump for his diabetes. He takes Tums, which is an antacid, at 750 milligrams per day for the calcium content. The patient also takes 1,000 international units per day of vitamin D due to his history of low vitamin D levels. He also has significant family history. His mother was diagnosed with Hashimoto thyroiditis. Also, his grandmother was diagnosed with osteoporosis in her 60s. There's no other significant family history of autoimmune disorders or genetic disorders. Also, the patient has no known drug or other allergies, no surgical history, and no significant social history other than being an active 14-year-old boy involved in sports. The physical exam findings pertinent to this case are as follows. First, he's in the 34th percentile for his weight, the 26th percentile for his height, and 42nd percentile for BMI. This is a pediatric growth chart, and the stars indicate where our patient falls. Along the horizontal axis, we have years for age, and on the vertical axis, on the top portion, we have stature or height and weight in the bottom portion. And we see that our patient is within normal limits of these intervals. Our patient is at Tanner stage 3 of puberty. The Tanner system is a sexual maturity rating system used to describe secondary sexual characteristics of patients. He has white sclera and normal dentition without caries. He does not have scoliosis or bowing in his bones and no birthmarks. Although he is thin, he presents with appropriate muscle tone. Based on our patient's presentation and past medical history of multiple fractures and an autoimmune thyroid condition, the following labs were ordered. His parathyroid hormone, calcium, phosphorus, alkaline phosphatase, and thyroid-stimulating hormone levels were all within normal limits. However, it's important to recognize that his 25-hydroxyvitamin D level was decreased at 20 nanograms per milliliter, when it should be between 25 and 100 nanograms per milliliter. We also ordered a DEXA scan, which is a means of measuring bone mineral density. A z-score of -2 or more negative is indicative of an abnormal bone mineralization or osteoporosis. The z-score measures the difference between the measured bone mass density and the mean value of age, race, and gender matched individuals, expressed in standard deviations. Our patient scan proved to be within normal limits for the femoral neck, left hip, and lumbar spine. You can see here the red zone would be abnormal or indicative of osteoporosis, and these lines indicate that our patient's measurements were in fact normal. Based on our patient's chief complaint, presentation, and the lab and radiology results, we surmised 4 possible differential diagnoses: osteogenesis imperfecta, hypophosphatemic rickets, Paget disease, and vitamin D deficiency. Osteogenesis imperfecta, also known as brittle bone disease, is an autosomal dominant genetic disease leading to a defect in type 1 collagen, specifically the alpha-1 and alpha-2 chain, which are essential structural protein for bone, ligament, skin, and sclera. Our patient does not have a family history of the genetic disease, and he does not meet the other clinically significant criteria, such as having scoliosis or blue sclera. In patients with osteogenesis imperfecta, the whites of the eyes or the sclera are blue, which you can see in this image. The only consistent clinical manifestation of our patient is the brittle bones, as indicated by the frequent fractures. Therefore, osteogenesis imperfecta is an unlikely diagnosis in this case. We next considered hypophosphatemic rickets, which is an inherited X-linked dominant disorder leading to the weakening and softening of bones. Individuals with this disease present with low vitamin D levels and fractures or pseudofractures, which is why we considered this for our patient. However, the patient does not have the family history of this genetic disorder that is usually consistent. Also, he did not present with the physical presentation that is consistent with hypophosphatemic rickets, especially the bowing of long bones. This X-ray is an example of what bowing would look like, and our patient did not present with this. Consequently, hypophosphatemic rickets is also an unlikely diagnosis. Next, we considered Paget disease. Paget disease is a bone metabolism disease in which the integrity of bones is jeopardized due to acceleration of osteoclast reabsorption pathways. A prominent characteristic of Paget disease is cortical tunneling seen on imaging. Cortical tunneling, which you can see in this X-ray here, shows loosened striations along the long axis of bones. And again, our patient did not have this on his X-rays. Although the patient presented with fractures in normal calcium and phosphorus levels consistent with Paget disease, the condition usually affects patients who are 55 years or older. And considering that our patient is only 14 years old, it's an unlikely diagnosis. Also, our patient did not present with the classical cortical tunneling that is consistent with Paget disease. Therefore, it is unlikely, and we ruled that out as a possible diagnosis. This brings us to our final differential diagnosis of vitamin D deficiency. Vitamin D deficiency is depicted by impaired bone mineralization leading to bones and non-traumatic fractures. Patients have low 25-hydroxy vitamin D levels, elevated parathyroid hormone levels, and elevated alkaline phosphatase levels. The abnormally low vitamin D level of 20 nanograms per milliliter that was present in our patient is highly indicative of a vitamin D deficiency. Although his parathyroid hormone and alkaline phosphatase levels were within the normal limits, the low vitamin D level is considered a gold standard for diagnosis. The patient's DEXA scores, Z-scores, were also within normal limits, and his fractures were of a traumatic nature, which is less consistent with vitamin D deficiency. However, the frequent fractures and chronic low vitamin D levels are indicative of the patient's manifestation of the condition. Therefore, our findings are most consistent with a vitamin D deficiency, and we'll move forward with treatment of this diagnosis. Now I'll pass the presentation on to student Dr. Eli Kelly, who will provide you with information regarding treatment, ethical considerations, and the appropriate patient education for this case.
Thank you, student. Thank you, student Dr. King. As she mentioned, my name is student Dr. Eli Kelly, and I'm happy to present to you about vitamin D deficiency. And I would like to begin by telling you about vitamin D, where it comes from in the body, and how the body actually uses it. And then I'll progress on to treatment and osteopathic manipulative medicine and patient education. So to begin, vitamin D is obtained in two ways. Primarily through sun exposure, about 90% of the time, and UVB radiation strikes the keratinocytes in the skin and converts pre-vitamin D into vitamin D. The remaining 10% is from our dietary intake. Now, this is from various meats, fish, and other fortified foods, and these combine to be transported to the liver, and where an enzyme 25-hydroxylase converts vitamin D to 25-hydroxy vitamin D, or calcidiol. Now, as student Dr. King mentioned earlier, this is what we test for in the blood to measure vitamin D levels. However, it is not bioactive, and because its half-life is several weeks. Now, in order to get our active form of vitamin D, calcidiol is transported to the kidneys, where another enzyme, 1-alpha-hydroxylase, adds another hydroxy group to make 1,25-dihydroxy vitamin D, or calcitriol. Now, as mentioned, this is our bioactive form of vitamin D. However, its half-life is only several hours. Therefore, it is much harder to test for in a regular patient. So, what does vitamin D actually do? Its main function is calcium absorption. Now, we have here vitamin D entering an apical enterocyte and entering the nucleus where it binds to its receptor. It then forms a heterodimer with retinoic acid receptor, and this complex increases transcription of calcium transport proteins, both on the apical and basolateral ends, as well as increasing transcription of proteins such as calbindin, which transport calcium from the apical to the basolateral end. However, vitamin D and its complex do not encode for ion exchange proteins, as we see over here, only the transport proteins themselves. Now, how does this relate to our patient? So we see that, as mentioned earlier, his calcium levels are normal. And since his vitamin D levels are low, we would assume that calcium would be low as well. However, in the body's quest to maintain homeostasis, it compensates for this. And this leads us into the complexity of vitamin D deficiency. So as we know, bones are the storage for calcium, and when calcium is lowered by a decreased level of vitamin D, the body compensates by releasing extra parathyroid hormone. In bone, parathyroid hormone has a very similar function to vitamin D in that it stimulates the osteoclasts. Osteoclasts are the cells that break down bone to release minerals into the bloodstream. Now, with extra parathyroid hormone, the osteoclasts begin to outpace the osteoblasts, which are the cells that reform bone from excess minerals in the blood. And while this maintains homeostasis in the blood, the bone suffers. As we see here, low vitamin D leads to low blood calcium, which then increases our parathyroid hormone secretion and then restores calcium balance in the blood, but bone suffers. Now, as mentioned earlier, parathyroid hormone increased levels are common in vitamin D deficiency. Now, given our patient's 3-year history with vitamin D deficiency, one would assume that parathyroid hormone levels would be increased by this point as well. However, this is not the case in our patient, and this is the complexity of the condition. It is not fully understood at this point. So I can't explain to you why his parathyroid hormone levels are normal. What I can explain to you is that his vitamin D levels are low, and we can treat that. So what actually causes vitamin D deficiency? Well, as I mentioned earlier, diet and sun exposure are how we create vitamin D, so that's where we're going to have a deficiency. He's either not getting enough sun or he has an insufficient diet. And in rare cases, improper kidney function or autoimmune diseases such as celiac disease or Crohn's disease could play a part, but given our patient's lack of significant family history in these areas, we're convinced that diet and sun exposure is our area of concern. Now, it is of significant importance that our patient also presents with type 1 diabetes. These conditions compound in their negative effect on the bone, in that type 1 diabetes affects the osteoblast function. So a low level of insulin in the body inhibits the osteoblasts. So now we have decreased vitamin D, limiting the osteoclast function, and low insulin inhibiting osteoblast function. So our bone cannot degrade itself to restore chemical balance of the blood, and cannot reform bone when there's excess chemicals. Also, hyperglycemia, like our patient presents with his elevated hemoglobin A1C levels, leads to excess calcium loss in the urine. This combines to lower overall bone density, as seen in our patient, and it predisposes him to fractures. And now, to treat our patient, our first option is 1,000 units per day for about 3 months of vitamin D before retesting, or 50,000 international units of vitamin D per week for 6 to 8 weeks before retesting. However, our patient has been prescribed 1,000 units of vitamin D per day for 3 years with no positive effects. This leads us to 2 conclusions. Either this treatment method is not effective in our patient, or more likely he is not taking his medication as recommended. So to avoid any complications with his integrity, we would like to opt for a 300,000 international unit vitamin D intramuscular injection, as suggested by Rao and his associates in a paper earlier this year. Now, this injection will return vitamin D levels to their normal limits much faster than a daily pill, and is easier to maintain thereafter. So once his levels have stabilized, we will maintain with a 6 to 1,000 unit vitamin D daily dose. Now, it is also important to note that emerging research is showing that not only do vitamin D deficiency and type 1 diabetes play a similar effect on bone, they're actually interrelated in and of themselves. Savastio and his associates earlier this year noted that type 1 diabetic children have an overwhelming propensity for low vitamin D levels, and this low vitamin D requires a higher daily insulin dose. So treatment of one disease affects the other, and it is imperative for our patient to alter his diabetes treatment to make a full recovery. Now, being osteopathic professionals, we would like to treat with osteopathic manipulative medicine as well. And given our patient's history of recent fractures and brittle bone state, we would like to avoid any high velocity treatments and instead focus on lymphatic and myofascial release. Now, we have a couple of ethical considerations with this case. First, our patient is a minor, so parental permission is required for any treatment. And even though he is a child, he does have the right to receive information, and his autonomy should be respected. Now, anytime a child presents with a history of fractures, abuse is something that we need to consider. However, given the nature of our case and the that fact that his fractures occurred during athletic activity, it is not suspected at this point that abuse is the case. However, we need to monitor this in the future if fractures continue. Now, to send our patient home, we would like to just explain to him what vitamin D deficiency is and show him through his lab values that he does in fact have vitamin D deficiency, and that this intermuscular treatment option is going to be most effective and be easiest to maintain, and that he also needs to alter his lifestyle by limiting his contact sports until his bone density increases. So to conclude, we were presented with a case of a 14-year-old boy with a history of fractures that were deemed with little provocation. Given his history of vitamin D deficiency and type 1 diabetes, it was deemed that vitamin D deficiency was the case. We deemed it necessary to treat with an intramuscular injection to avoid any integrity issues with our patient, and would like to follow up with altered diabetes medication as well as continued vitamin D monitoring in the future. So here are our sources, and I would now like to open the floor to questions. Thank you.
You have some questions? You have a lot, okay.
All right, I guess I'll go first. So we've talked a lot about connective tissue here, bone specifically. We received a question about another type of connective tissue involving Ehlers-Danlos syndrome, which is a disorder of collagen. A lot of times with Ehlers-Danlos, you'll see loose skin, hyperelastic joints, and that sort of thing. You'll also see disorders in the vasculature.
I'm student Dr. Julia Loria. We received a question wondering how we decipher between bone fractures and if it's a metabolic disease or if it's an issue with child abuse. And so what I was looking at is that usually the question of child abuse is always raised when you have issues with bone fractures in a child. And so the way to rule out child abuse is to actually go through the complete examination. And so because our patient presented with lab findings of a vitamin D deficiency, we were then able to rule out child abuse for the most part. However, the presence of a metabolic bone disease, you cannot completely exclude concurrent child abuse, so we should also look into that.
Hi, I'm student Dr. Jennifer Johnson, and my question is, what are pseudofractures? So pseudofractures are also known as looser zones, and they aren't true fractures of the bone, as the name implies. They are a thickening of the periosteum and new bone growth at the site of injury to the bone. And the injuries show up as loosened areas in the bones when they're seen on x-rays or other radiographic imagings. And they are the characteristic radiological findings seen in osteomalacia and rickets.
Good morning, I'm student Dr. Portia Leatham. We received several questions about what is a DEXA scan and how can you use it for as a diagnostic tool. So DEXA scan, it's a imaging technique that looks at bone density, bone mineral density. The way it typically works is you'll have a fan beam source of radiation that will be passed over the area you're interested in looking at, and on the other side of your subject you'll have multiple detectors. And what you're looking at is attenuation or loss of that flux through the material, and then you want to use that to assess the bone mineral density. For this, there are two different types of scores you can use, a T-score and a Z-score, which, as Sarah mentioned, was what we had for our patient. The only difference between these, you're still comparing bone mineral density of the subject to other populations, but the populations are different for a T-score versus a Z-score. For T-scores, you are comparing against just your average healthy person. Typically, you're looking at 30 years old, whereas for the Z-score, as Sarah mentioned, it's age-matched, race-matched, gender-matched. It is nice if you have a T-score, because you can get more information from that. You'll have ranges for your T-score that will give you information. -1 or more positive would indicate normal bone mineral density. -1 to -2.5 would be indicative of osteopenia, which is decreased bone density, and -2.5 and more negative would indicate osteoporosis, which is even more significant bone loss than osteopenia and increased risk fracture. For the Z-score, the information that it tells us, we can really only look at how it is in comparison to that -2 value that Sarah discussed. Anything below or -2 or more negative is indicative of abnormal bone loss and suggests that you should look for an underlying cause. It doesn't really necessarily matter how close it is to -2, because more positive than -2 is still normal no matter how close you are, if it's -1.8 or something like that.
Good morning. My name is student Dr. Seth Larson. I got a question regarding the function of vitamin D in the renal system. Vitamin D plays a very small but indirect role in the kidneys as far as calcium absorption goes, but it mainly acts in concert with parathyroid hormone to accelerate calcium reuptake in the distal tubule, but has no direct function on calcium absorption itself. The most important role for vitamin D in the kidneys is actually self-regulation of its own production. It controls its own homeostasis through suppression of two different enzymes. Suppression of one enzyme that actually activates vitamin D, and then it also stimulates the enzyme which degrades it. So this is an important negative feedback mechanism that prevents an excess of calcitriol in the blood. And it also has the ability to induce expression of proteins that facilitate its own uptake, or reuptake in the proximal tubule if more vitamin D levels are needed.
Hello, I'm student Dr. Chris Conkle, and we had a question about the level of calcium in Tums. As noted, we used Tums as supplementation for calcium deficiency in our patients. And typically we think of Tums as an antacid, but it actually contains levels of calcium carbonate at about 500 to 1,000 milligrams per tablet. However, calcium carbonate levels only contribute about 40% of our body's elemental calcium, so we actually get about 200 to 400 milligrams of calcium from each tablet of Tums.
Hello, I'm student Dr. James MacDonald, and I had the question of what is the difference between osteopenia and osteoporosis. So I went to UpToDate to find the difference, and I found that osteoporosis is the common disease that is characterized by low bone mass, microarchitectural disruption, and skeletal fragility, resulting in an increased risk of fractures. And the difference between that and osteopenia is the process of the thinning of the bone mass. And while this process is considered not as severe as osteoporosis, it is the process that leads to osteoporosis. And so to be able to diagnose the difference is done by measuring the bone mineral density.
Hi, good morning. My name's student Dr. Fez Kidwai. One of the questions we received was on the association between type 1 diabetes and low vitamin D. The short answer to that question is yes, indeed, there is an association between the two. However, I want to predicate my response on a couple of things. First, as student Dr. King mentioned that the patient has experienced problems controlling their symptoms of diabetes. And one should keep in mind that controlling the symptoms of diabetes is not just difficult for younger individuals, but it's also difficult for you know, adults as well. So just something to keep in mind in case that reflects poorly on the patient. Furthermore, according to our research, the relationship between between vitamin D deficiency and other comorbidities like type 1 diabetes is poorly understood. So just wanted to predicate my answer on that. So vitamin D deficiency is frequently observed among individuals suffering from type 1 diabetes. And there have been studies indicating a positive correlation between 25-OHD levels and insulin sensitivity. So this particular study that I'm referencing, if one were to extrapolate data from that, if you were to increase the serum concentration of 25-OHD from 25 to 80 millimoles per liter, it would result in insulin sensitivity. It would increase insulin sensitivity by 60%, which I think is pretty extraordinary. Conversely, if in non-diabetic adolescents and children as well who have low levels of 25-OHD, that is commensurate with increased insulin resistance among individuals who are at risk of developing diabetes. But with all of that said, one other caveat, that association obviously does not imply causation. So
He may have answered it already, but I know we have one more question that came in. So who's going to take that? Yeah. That hasn't been worked up yet, right? You have it? Okay, let's just go ahead. I want to emphasize a couple things here. Number one, I haven't had endocrinology yet. Number two, yes, the faculty was involved in mentoring, advising, making suggestions, but the vast majority of this is self-taught. And I'm going to compliment you on the work that you've done, and particularly on the quality of the answers to the questions that you've received. I think I know more about DEXA scan than I'll ever want to learn, but that's a very comprehensive answer, as well as your answer down here. Do you have that question? All right, we'll let it go. Oh, go ahead, please. Here.
The question was, is there any link to vitamin D deficiency in autoimmune diseases? So according to some research at Oxford University and a genome research, there is a genetic link to the idea that vitamins can interact with genes specific for colorectal cancer, multiple sclerosis, and type 1 diabetes.
All right, well, we hope you enjoyed it. Let's give them a good round of applause and have a nice afternoon. Nice job.